Next session, which is troubleshooting the toric IOLs. So, good evening everyone. I'm Dr. Vanushree Nair, and we are having an interesting session on troubleshooting the toric IOL game. I would like to invite Dr. Rajesh Sinha sir, Dr. Harshal Tak sir, Dr. Tushar Grover to come on panel, please. So, as we all know, Dr. Rajesh Sinha is Professor of Cornea, Refractive and Cataract at RP Center. So, I'll start the session with my talk. Why the necessity for toric IOLs? We know that toric IOLs have been around for more than 1.5 decades now, but many surgeons are using toric IOLs, but there is still a lot of hesitancy among the young surgeons or even intermediate level surgeons to take up toric IOLs. So I'll briefly go through why do we need to take up toric IOLs. So now we know that with phacoemulsification and better surgical techniques and smaller incisions, we have a better predictability of the post-operative refraction that will come for the patient. So, and also with better biometry and better IOLs, cataract surgery has become a refractive surgery. Hence, we need to give the best that we can to the patient. So, astigmatism prevalence in cataract surgery, as we all know, it is almost approximately 50% of your cataract surgery patients will have one diopter or more of pre-existing corneal astigmatism. So, these are the patients who will benefit from a toric IOL. So, we need to address this issue. So as we all know that a vision with even a small amount of cylinder will not be as crisp as without astigmatism. So your daytime vision and also the nighttime vision will be slightly distorted or blurred when there is little amount of astigmatism remaining. So toric IOLs were introduced by Shimizu et al. In 1992 as a rigid 3-piece lens, and it underwent a lot of modifications as to what we have today. So we all know that it is the acrylic hydrophobic platform which is used to place the toricity, because these are known for their stability, because they adhere to the capsule and a profound shrink wrap effect occurs which keeps the IOL locked in place for years. So what the notification used? How do we describe the toricity? So basically when you see these numbers, you'll get confused. Different lenses have different notations. So it is basically to describe the power which is there on the IOL, how it will translate to the power which will reflected on the cornea. So it is obviously going to be lesser. So now we know that all the premium IOLs which are available are also available in the toric platform, because as we are promising the patient a better vision, we need to take care of these small to moderate or even high astigmatism that the patient may be suffering from. So advanced monofocals, the multifocals, trifocals, EDOFs, most of the lenses also have the toric platform on them. Now, which are the cases that we will go for a toric IOL? So, most important thing that we need to remember is it is the pre-existing regular corneal astigmatism more than 0.75 or 1 diopter that can be addressed. Now, situations like glaucoma, epiretinal membrane, macular degeneration and other pathologies will also benefit. They are not contraindications for toric IOL. The only place where it may be contraindicated, as we know, is irregular corneas or those patients who have so much of irregularity that they need RGP or scleral contact lenses to regularize the surface. There, the toric IOLs will not benefit. So how do you go about? Now, when you're planning your early toric cases, you're doing fairly good, you're getting consistently good results with your monofocal IOLs, your biometry is well adjusted, you're happy with your results. Now you need to step up and you want to promise something more to your patients. So how will you begin? So first, most important thing to remember is it is the regular astigmatism. So as we know, it is the angle between the two principal meridians when they are perpendicular. So with the rule, against the rule, oblique and bioblique, that is the definition. So here we are dealing with regular astigmatism. With the rule means your steep axis is going to be vertical, and against the rule means the steep axis is horizontal. These are the two criteria which you need to remember. Now, which patient to choose? Now, when you're going through the biometry of the patient, just keep an eye on the keratometry readings. Is there a significant astigmatism? Is it very small? Is it significant that where you can implant a toric IOL? So choose a patient initially who will be a little more forgiving, maybe around 1 to 2 diopters of astigmatism. Explain the additional benefit that the patient may get. Don't overpromise that it will be bang on 0, refraction, but try to deliver on target. Very important to remember that before you do your biometry, the surface needs to be good. There shouldn't be any severe dry eye, meibomian gland dysfunction. If there's a pterygium, you need to deal with that before you plan a toric IOL. Because these problems will give you unreliable and inaccurate readings. So you stabilize the surface and you repeat the readings. And if there's confusion, then compare your biometry and topography readings as well. Another concept to remember is the axis notation. So here it starts from the left eye laterally, that will be 0 to 180, and then in the right eye it will be nasally starting 0 to 180. Coming to biometry, so it is the corneal keratometric astigmatism we are going to deal with and not the total refractive astigmatism. So keratometry, you always try to use 2 instruments, either use your auto-K instrument, the biometer, or a tomographer. Now the OCT-based systems like IOLmaster 700 and Anteoron will also give you the K readings. Important concept to remember here is the posterior corneal astigmatism to be taken into consideration. So when you're doing the keratometry, it is giving you only the anterior curvature. But the posterior corneal curvature also plays a role in the total corneal astigmatism that is there. So Dr. Douglas Koch found out that the effect of the posterior corneal astigmatism, it is in the vertical meridian. The posterior steepest meridian will almost always be vertically aligned. So that will give you an error while you are calculating. With the rule group, the overcorrection will be almost of 0.5 diopters, and against the rule, there will be an undercorrection of 0.3 diopters. So the machine should be able to calculate for the same. Now, coming to another important concept which everybody of us is scared of is there is some surgically induced astigmatism. Now, how to incorporate that, what to do. So drhill.com gave a surgically induced astigmatism calculator to calculate your SIA, which was initially based on the median value, so where you input your own data of around 30 to 50 patients, how much ever you can, and that will give you a median value of what is your overall SIA for your right eye separately and your left eye separately. Then it also came to the centroid values, which is actually a little simpler to understand. So the software also gives you the centroid value of your SIA. Now what is SIA? It is basically the flattening effect that will come because of your incision. So it is a vector which is composed not only of the flattening steepening effect but also the torque. So mathematically it becomes a little more daunting to the surgeon as to what is exactly happening. So what happened is Dr. Hill observed that, if you're going with a temporal clear corneal incision, then and you use a centroid value which between 0.08 to 0.14, then most of the surgeons are falling in that group. So what he suggested is that if you have not gone ahead and calculated your own SIA, then you could use a mean centroid value of 0.12 while using the toric calculators. And he suggests that using the temporal clear corneal incision. Now coming to the biometry that we use for the eye power calculation, optical biometer is the best, but in some situations where you cannot use the optical biometer, it is better to use the immersion over the contact one. Now calculating the spherical component is the one of the crux things that we need to do. So we know that the newer generation formulas like Olsen and Barrett's Universal 2, which are incorporated in most of the newer optical biometers, they'll give us a good spherical power of the lens. Then the toric IOL power calculation, if you're using an optical biometer, something like Lenstar 900, IOLmaster 700, Anteoron, OA-Tommy, then we know that they have these calculators embedded on the system itself, and best of the IOL power formula will be used, and you will be able to get your IOL power with the toricity. But if you're not having these optical biometers, then you can even go online, use the Alcon online calculators, or Biotech online calculators, or the ASCRS Barrett's online calculator, or the Assort, and the other examples. So this is an example of the Lenstar 900 and the IOLmaster 700 about, it gives you all the values of what is the corneal measurements that you have, and it gives you the suggested lenses and the toricity that you can use, at what axis you can implant them, and what is the residual astigmatism that will remain. Just sharing an example of the Barrett's Toric calculator. So this is a free online software that is available. You just have to enter your data, the patient's name, age, the lens that you want to use, the lens factor, and you have to give the flat K, the axis, the steep K, put the axis, the axial length, all the parameters that you have that needs to be, that will add to the accuracy of the IL power that it calculates, and then it will give you the IL power as well as the steep axis where you need to implant the IL. Another is the AIOC software, but it is not a free software, you need to pay for it. Again, based on similar principles, and it uses multiple IL formulas, and it gives you the vectors in which your incision and the IL will act. Among the Indian platform, you have the ICRIL Toric, that biotech example that I would like to share. Similarly, you can input your data and it will give you the examples in such a format. It is important that on these IL calculators you note that the posterior corneal astigmatism is taken into consideration when the software is calculating your IL. So it usually gives you 3 options which will correct your astigmatism to the best level. You need to see that the residual astigmatism should be minimal. Like if you see in option 1, the residual astigmatism is 0.27 at 178, which is still remaining against the rule. In option 2, if you see, the residual astigmatism remaining is 0.24 diopters at 88. So it is going vertically steep. So it is going slightly to the with the rule astigmatism, which is a preferable thing to do. So in this option, in this case, I would go for option 2 IL in this case. So, like the example I was saying, it is better to keep the patient with the rule, the smallest residual with the rule astigmatism would be better while choosing which IOL needs to be implanted. So that with that I come to the end of my talk, and I would like to invite Dr. Rajesh Sinha sir to explain the surgical tips and tricks to have the perfect toric IOL implantation.
Thank you very much, Dr. Vanashri. That was a wonderful overview and how to prepare the patient for putting the toric IOL. So it's very important to note that whenever we counsel our patient, the biometry has to be done first, especially keratometry, because once you've done all the counseling about all the lenses, and then when patient go for biometry, you find out that he has a cylinder and he needs to be corrected. So everything, your packages, everything changes. So you have to do counseling before you have done, after you have done your biometry, that's very important. So if you have a case situation where your keratometry readings are different in your keratometer and your biometer, so how do you decide on magnitude and axis, that which axis to choose and which power to be taken into consideration? So because it's not possible that you always have 5 readings from your biometer, 5 readings from this. It's difficult to decide that what axis and this.
So firstly I would like to repeat the readings on another day, because many a times there are manipulations which have already occurred. The patient has been dilated, or maybe the pressures have been checked with applanation tonometry. Some of the other manipulations have happened. So I prefer that if there are changes coming, then I'll repeat the readings, and my preference is usually to go with the optical biometer readings than the keratometry, like the auto keratometer readings.
And about axis, I think it's better to go for tomographer, for sham flow. If you have variable axis, so your tomography gives you better about the axis and this. And another method, if I have started using recently, is use integrated K. There is a recent paper which proves that if you use integrated K rather than simply use keratometer readings from one instrument, that gives a better result. So in Barrett calculator now there is integrated K option which is there. You feed in K reading from your auto K, you feed in reading from biometer, you feed reading from your tomographer. So that gives you average of that K, and they have proven by studies that it gives a better result than using keratometry from a single instrument.
Yeah. But if you want to use a single instrument, I would say if there is any doubt, then Scheimpflug imaging should be preferred over keratometer or anything. Yeah. So thanks a lot, Dr. Vanashri, for having me in this very interesting course. regarding Toric IOL, and I'll be talking about the preoperative planning and axis marking and placement. I don't have any financial interest. As you all know that a lot of patients, about one-fourth of patients, they do have significant astigmatism, and they do require correction of this astigmatism, because the visual acuity, if you measure, it can be close to 6.6, but the crispness of vision is not there if the astigmatism is not fully corrected. And that is true if you don't correct the astigmatism. And that's why it's very important to think about the cylinder as well as sphere. And another point I would like to mention here is that when you're starting your practice of Toric IOL, many times you fear that if it's slightly off axis by 1 degree, 2 degree, we have been reading theoretically so much, then it will cause a lot of problems. Little bit of 1 or 2 degrees here and there, it doesn't make much of a difference, and these Toric IOLs are very forgiving. Even if you when you do a post-op, if you do refraction and then if you get a little bit of cylinder, the eye is such and the defocus system of the eye is such that the patient does not have much problem and the patient has a crisp vision. So what is most important is that we have to decide first that how much is the cylindrical power, and we correct the corneal cylindrical power, because in any case we are removing the lens. So if there is any issue related to lens related cylindrical power, we don't have to think about that internal astigmatism, we just have to think about the corneal astigmatism. That is one. So an accurate measurement of astigmatism and axis is important. Second thing is you have to mark properly. Marking is important. That should be accurate, because then you will place the IOL over that axis. So the marking is essential, and then of course the placement of IOL. The patient selection, in patient selection you keep all those patients who have regular astigmatism, not irregular one. You can do keratoconus, etc. Some unique cases as well wherein there is no progression, which Dr. Tushar will be discussing with all of us. Conditions wherein we may require a corneal procedure later, something like somebody is having a Fuchs dystrophy or a stromal dystrophy wherein you have to do a corneal procedure. In such cases, we should avoid using Toric IOLs. And as I said, Toric IOL cylindrical power is based on corneal astigmatism. Shim imaging is done. Patient evaluation, Dr. Vanashri has already done all these IOL power calculations. I'll just skip that. And I'll just move on. I'm sorry for that. Coming to the marking. So the first thing, as I mentioned, is the marking on the cornea. So how we should do it? We can do it manually, or there are options of digital marking, wherein you don't have to mark, but you get under the microscope, you get the exact axis. Many of us will not be having the digital system. So manual marking is a good way of doing it, and studies have shown that if manual marking is done appropriately, properly, then there is hardly any difference between the manual marking and the digital marking. So the most popular method of marking the cornea is the bubble marker. Here you have a bubble, as you can see. It should be in the center, and then you put some gentian violet over here and then place it over the cornea and mark it. What is essential is that the patient should be upright. The patient should be standing or sitting. Best thing is that if you have a wall, then you ask the patient to stand there opposite wall, so that you can directly see that there is no head tilt, etc. So if the head is right straight, then in that case you can just put a drop of proparacaine and then you can mark it directly. Asking the patient to stand against a wall is very helpful, because then the patient has a tendency to remain straight. That is the advantage. Another method is that you can directly mark. You ask the patient to look straight ahead, take a marker and you mark directly the 6 o'clock position. But then 6 o'clock position marking can be done by that as well. Then people have also used pendulum marking, or there are various other methods. On slit lamp, you can mark, you can put the slit beam like that, and then you can mark 0180, you can mark 12 o'clock, 6 o'clock. So all these things can be done manually very reasonably accurately, and these are all reference marking. And once the reference marking has been done, this is done because in the sitting or standing position, because once the patient lies down, there is an element of cyclotorsion, and nobody can predict. We have published an article on cyclotorsion, and we found out that cyclotorsion can be clockwise, it can be anti-clockwise, both ways. It can be 7 degrees, it can be 10 degrees, it can be 14 degrees. So the maximum that we got was 14 degrees in our study. So because of that, we have to mark it in a sitting position, and then once the patient lies down, we have, based on the 0180 and 6 o'clock position, we can mark the axis exactly. And once the axis is marked, you align the IOL along the axis, and this is how it looks like. You can see the mark here, you can see the mark of the IOL and the mark on the cornea. So there are various situations, there can be various positions of axis wherein you can place, and as you can see here, once again it's a little faint, but the mark is here, and this is the dots on the lens. Sometimes you have a scar in the peripheral cornea, and sometimes you have a scar in the peripheral cornea. If you have a scar in the central cornea, it is not advisable to put a toric IOL, because it will cause irregular astigmatism. But sometimes a scar in the peripheral cornea can have an astigmatism which can be measured in the two axes, in the two meridia, and there you can place the toric IOL. Another scenario which I would just like to add here is cases of megalocornea, wherein you have a large bag. In such a case, wherein if you put the IOL in the bag, it will rotate. And this we learned from a case which was referred to us, a case of megalocornea, wherein the IOL rotated, and then again the surgeon re-rotated it in the same position, and again it rotated. Then the patient was referred to us, and then he found out that it has a megalocornea. And from there we learned, and then what to do. And then in such cases, the best thing is to put the IOL in the bag and do a reverse optic capture along the axis. So as you can see here in this case, the IOL has been put in the bag. Viscoelastic you should remove from the front and from behind, and because removal of viscoelastic from behind is very essential, otherwise there is risk of post-op rotation. And once you have removed that, you can inject some viscoelastic to maintain the chamber, and then go behind the IOL and bring it anteriorly once you have rotated it along the axis, and do a reverse optic capture. So in cases of megalocornea, which you get very infrequently, but yes, we can do that and have a stable IOL in position. Other method is markless alignment, that is digital method, that is we have Callisto eye in the Zeiss microscope, we have Varion digital marker, we have ORA, that is optiwave refractive analysis. So in Zeiss microscope, I don't have any financial interest, they have the Callisto system, wherein you get this, this is the reference marking 0180 degree, so you can place the incision along that axis, and then this is the axis along which you have to place the IOL, you have to align the IOL. I'll just show you a small video clip. So this is the reference marking. So you have made an incision, you make the incision along this reference marking, and this is the central line, the blue line is the line along which you have to align the IOL axis. So once you have implanted the IOL in the bag, you remove the viscoelastic from the front, from the behind, and while removing the viscoelastic, if you are using a coaxial, you can rotate the IOL, or you can bring the IOL close to the axis before removing the viscoelastic, and then remove the viscoelastic. So all these things can be done. You can modify your technique the way you want. Finally, what you want is the IOL, this mark to be aligned exactly along the central blue line. That is what we want. Varion reference unit is there with the Alcon system, and they also, it basically measures the axis, and then based on the scleral blood vessels and the uveal structure, it gives you the idea about the axis. And this is how it looks like when you place the IOL along the axis. This is how you have to align it. Then ORA system is again, that is OptiWave refractive analysis, is again a digital method of aligning the IOL. And in that, once you have removed the cortex and nucleus, then you inject viscoelastic, form the chamber tight, and then use the ORA system to calculate the exact power of sphere and cylinder and the axis, and then you place it accordingly. And once you have placed it, what you want to see is, once you have put the IOL in position, aligned it along the axis, then you again do ORA. And then if you get NRR, that is no rotation recommended, then you don't have to do any rotation. Otherwise, it will give you an idea that, see, you have to rotate this much counterclockwise or rotate this much clockwise. So that is again a method of doing it if you have this ORA system. And but once again, having said that, these are all expensive equipments, and if you don't have these equipments, it doesn't make much of a difference, because studies have shown that appropriately done manual marking is comparable to all these digital marking methods. And as Vanashri was mentioning, the current generation hydrophobic IOLs, they have that shrink wrap effect. And if you have a good capsular axis which is just covering the IOL optic margin, it will have a nice shrink wrap effect. And if you have removed the viscoelastic from behind the IOL, there is no chance of any post-op rotation. And if you have any such thing, Dr. Harshal will be mentioning about all those surprises that we can get after implanting a toric IOL in its position. So thank you very much. I will thank Dr. Vanashri once again for the opportunity.
Thank you so much, sir, for the wonderful insights and tips into the surgically managing placement of the toric IOL. So just one question I would like to ask. Sometimes when we are placing the toric IOL along the axis, the lens kind of doesn't sit in the place and tries to go a little away from the axis that has been marked. So any tips to the new surgeons how to align in that case? Like, should we re-rotate the new?
No. The best thing is that don't put it, when you are rotating it, just keep it a few degrees before the exact axis.
Right, sir.
Because when you are hydrating, what happens that sometimes it has a tendency to rotate little bit. And if it rotates little bit, it will come into bang into axis. If you have put it bang on axis, it will rotate. And then you cannot rotate opposite side. You have to rotate it clockwise only.
Right, sir.
So it is always better to place it in the axis, maybe just about 5 degrees before the intended axis, so that when you are hydrating, if it rotates little bit, it can come in position. Even if it doesn't rotate, with the simple BSS cannula, you can simply put some BSS, and with the cannula you can bring it in position. So that is important when you are placing the IOL, particularly not for the beginners, even for everyone, for experienced people also.
Right, sir. Thank you, sir. Thank you so much. So next I welcome Dr. Harshal Tak from Jaipur. He's a prolific cataract and refractive surgeon, and he would be talking on toric IOL refractive surprises. So how do we manage ahead that we have implanted a toric IOL and now the result is not optimal? Thank you, sir. So what to do next? How do we evaluate this and how do we correct this?
Thank you so much, Dr. Vanashri. So can I have my... Okay, right. So before I start, I'd like to show two slides here, because this topic is so close to my heart. So this is the way, as Dr. Rajesh mentioned, and for the benefit of the youngsters, that how do we mark on slit lamp. So I just want to show one video here. So always keep this slit beam horizontal and make it very thin. If you can see here, this is a 26 gauge needle which I'm using. Because if you directly try to mark with the ink pen, it makes almost which is 5 to 7 degree. It's thick. So this is a 26 gauge needle or 20 or 30 gauge needle which you can use. So narrow down on slit beam, and you can see I'm scratching on the corneal epithelium here. So once you have put these scratch marks on the epithelium on both the sides, the advantage is even if your ink mark fades, these scratch marks will remain when you take the patient in OR. So once you have made these scratch marks here, then go and put some ink on the tip of 26 gauge needle. So the advantage is you get a very thin mark there, and as well as you get a scratch marks on epithelium. So this is the first thing which I wanted to share with you. And next is we are talking about implantation of IOL. So what I described in 2010, the technique of hydroimplantation, and I coined this term, and this technique is very useful in toric and multifocal and trifocal cases, because we all know that if we have any residual OVD leaving behind the IOL optic, it may cause post-operative rotation of the toric IOL. So we should always try to use this technique, hydroimplantation. So you go ahead and put irrigation cannula in the anterior chamber on the irrigation mode. So once you have this irrigation cannula, it maintains the anterior chamber depth as well as capsular bag. And when the IOL is unfolding, keep the tip of the irrigation cannula over the IOL optic. So this is a mistake which many surgeons do, and I see a lot of videos that just keep irrigation cannula here at the side port incision. So this IOL, when it's unfolding, it may rotate, it may flip. So if you keep this irrigation cannula tip over IOL optic, it will not let this optic rotate. So once you have the IOL in capsular bag, see it's very well maintained. So use Kugelens hook to put the trailing haptic in the capsular bag. And it's very important that you have a perfect size of capsular axis. So here, this axis is smaller in size. So when you're talking about the final alignment, so before you do final alignment, this is the mark where you need to align. You need to enlarge the axis to desired size before aligning it. So again, just put irrigation cannula there, and you can enlarge the axis to desired size. And after that, just under irrigation, you go ahead, use Kugelens hook. And these are the marks where we need to align the toric IOL. And you go ahead and align the lens. So, and this is the hydro stitch cannula which I have designed. So you go ahead and put IOL in the right place, and just hydro stitch all the incision, and you have IOL perfectly at the perfect location. So these are a few tips I wanted to give about this, but we may have surprises in post-operative period. So let's see how do we tackle those surprises. Okay. So we all know that even small errors in position of the toric IOL may significantly affect the patient uncorrected visual acuity. So what are the causes of the toric IOL surprise? Firstly, that there is a pre-operative measurement errors. You didn't measure the keratometry perfectly, axis perfectly. There may be problem in the marking of the reference points of the cornea. So you should always check whether your 0 and 180 marks are in the proper plane or not. So it may give rise to toric IOL surprises. And if you have not placed the IOL correctly, suppose there is by mistake you have done wrong calculations and you have placed the IOL in the wrong axis, or you have failed to take into account the effect of post-coronal astigmatism or your SIA, or there may be problem in the IOL placement, of which because of the tilt there may be surprises. So we all know that how to check the position of toric IOL in post-operative period. We dilate the pupil and we narrow down the slit beam and align it to the toric IOL marks which are there. So once you align these marks, so on slit lamp there is a angle which you can make out using this, or this is the optical biometer OA2000 which I use. So it captures the image like this, and it gives me at the difference of 1 degree that what is the IOL axis as compared to the reference axis. So when I check on this, so this is my reference axis and this is the IOL axis. You can rotate it at the 1 degree. So here it shows that IOL axis, this is the yellow one, it is at the 87 degree. Even though this is the photograph which I have taken, you can't make out clearly the toric IOL marks here, but you can easily make out when you see on that screen. So what are the options we have if we have post-operative toric IOL refractive surprises? That we go and do some calculations online, which I'll be showing. If those online back calculators gives us that the rotation of the IOL can cause reduction of refractive cylinder, we go ahead and do rotation of the toric IOL. If those calculators show that they won't have any effect on the post-operative toric IOL surprise, then we have an option of exchanging the IOL or putting a piggyback IOL of residual refractive error over the existing IOL. And if we have large magnitude and access problem, then maybe LASIK or PRK we have to do in these kind of cases. So this is the online toric calculators. This is astigmatismfix.com, which is developed by Badal and Hardin. So what essentially you need in the data which you need is what is the current refraction of the patient right now, and what is the IOL axis where the toric IOL right now is sitting. So if you feed on these data, this calculator give you the rotation which is required to correct the residual cylinder. This is the ASSOT toric calculator, which also can be taken help from. The same data is fed in all these type of calculators. So these are various calculators. Even Barrett has Barrett RX formula, which can tell you whether you need to rotate the IOL or you need to put a piggyback IOL or need to exchange the IOL. So I'll just share one case here to make it very easy for you to understand. This was a referred case on 12th day post-toric IOL surgery, and patient had uncorrected vision of 636, and his refraction was -1 sphere and plus 2.5 cylinder at 140 degree. So with this refraction, patient was reading 6.6, and this was the surgeon told me that the T6 IOL was placed at 10 degree. So this is the data which I have, and the patient is very much dissatisfied because of the vision which is very poor. So I go ahead and dilate the patient and check. So we go ahead and check where the IOL toric IOL is now sitting. So I go ahead and check that yes, it's 10 degree. So toric IOL where the surgeon implanted at 10 degree, it's at 10 degree, but still he has a refractive surprise. So I go ahead and check on optical biometer. It's showing me that IOL is at 10 degree, IOL axis. So I go ahead and use this online calculator. So if you can see, I feed in here that what is the toric lens and axis, what is the current refraction. So I feed in the current refraction. So what this calculator shows me here is the ideal position of the toric IOL has to be 175 degree. So it gives me the data that I need to rotate my IOL from this blue line, this blue position to this position of 170. So I need to rotate it in clockwise direction 15 degree. And this will reduce the cylinder to minimum of 0.24. So now this calculator has given me that I need to rotate it 15 degree in clockwise direction to reduce down the cylinder. So this is how we calculate that what is needed. So I go ahead and see how this case was done. Now we don't need to mark the reference axis here because these IOL marks are acting as a reference axis, and we just need to go 15 degree in clockwise direction from here. So I go ahead and put align 0 and 180 degree to these toric IOL marks, and using these I mark on both the sides 15 degree in clockwise direction. And after marking, I go ahead and this is 14th day, that is 2 weeks after the surgery. Go ahead and just put irrigation cannula through side port. So I opened up the same side ports there and just use Kueglen's hook. I go beneath the anterior capsular axis margin, separate it from the IOL. So we don't need any OVD here to rotate this lens. Just put irrigation cannula there. Use Kueglen's hook to rotate the IOL. So now we have IOL which has been rotated 15 degree to the desired axis here. And this finishes the case. So in the next post-op day, you can see the IOL which was there, it has been rotated 15 degree, and patient had uncorrected vision of 6.9 and best corrected with 6.5 with minus 0.5 cylinder. So this is how you can use these calculators to tackle any post-operative toric IOL surprises you have. So thank you very much for
Thank you so much, sir. That was a wonderful demonstration of how we can tackle with these surprises. I think that will allay our fears quite a lot because that gave an insight into how we can use the online calculators to find out where things have gone wrong. Is it the IOL which has rotated, or is the power calculation wrong? And we can take corrective steps and have a good outcome.
Can I ask
Yes,
a
sir.
question?
Yes, sir. Sure.
Yes, yes.
Arshul,
Yes, sir.
what is the ideal time to rotate a IOL if your axis is not correct? Number one.
Yes.
So before the adhesions develop, or you have to give some time also for the lens to settle down. So what is the ideal time? Number one. Number two is that if you have a bilateral patient, you've operated one eye and you landed up with a rotation, and the patient had a very small pupil, so it was not possible on the table to correctly put the IOL. Now you are planning the second eye. Would you like to do the second eye after 2 weeks, then do the rotation, or first would you like to rotate the lens in the correct direction, see the result, and then go ahead with the other eye?
Okay. So
And
there are
this
so
is a multifocal lens.
yeah, whatever.
Extended depth, whatever.
Yes. So they are
So
so
happy.
yes. So I think the best time to rotate the toric IOL, it depends on, suppose you have a patient on first post-op day, you see that patient is highly unsatisfied, your own patient. You go dilate the patient, check that there is gross misalignment. If you find that there is gross misalignment, that can only happen, believe me, nowadays because of either flipping of axis or your calculation have been grossly wrong. Rotation of IOL, I think with these lenses, newer lenses, is not an issue. In these lenses, rotation is not an issue, and especially I use hydroimplantation. I hardly see any rotation in these lenses. So if there is a flipping of axis, suppose your assistant has totally flipped the axis, they have calculated, you have to go ahead and do on the very next day. You can't wait for that lens to rotate on its own or whatever. So you know that it's 90, it's 180. So you have to change the axis to desired. Secondly, if
full IC. So I'll be talking about toric IOLs in special situations where you can do them, where you cannot do them, and where you should be aware of the challenges involved. So the specific case scenarios that I'll be discussing are eyes that are post-refractive surgery, those with corneal ectasia, and eyes that are post-keratoplasty. So let's start with post-refractive surgery eyes. So essentially the challenges that you have in these eyes pre-operatively are to get the keratometry right and subsequently the IOL power calculation. Then you have the next challenge of choosing the intraocular lens you're going to be implanting. The limitations that your keratometers, placido topographers, and some of the optical biometers have here is that they're essentially measuring only your anterior corneal curvature. They're not measuring the posterior corneal curvature. They are assuming a ratio between the two, and they're also blind to the exact center of the cornea, and they're also extrapolating that information. So all of this is fine when you're looking at virgin eyes or healthy corneas, but that's not valid when you had an eye that has undergone refractive surgery. So this is where I find Scheimpflug tomography to be extremely useful in these set of eyes. The map that I like to use is the Pentacam EKR map, and I'll just discuss this map because I'll be showing this map in the other case scenarios as well. So this essentially calculates the equivalent K reading values of the cornea in 2 steps in such a way that you can feed these keratometry values directly into any IOL formula that is using a refractive index of 1.3375. So let's look at this eye here. This is an eye that has undergone refractive surgery. You can see the equivalent K readings in different zones, and this is centered at the pupil. You see this histogram here, you can see there's a single uniform peak there. This is an indication that this is quite a regular cornea. When you look at the K values also across different zones, you can see that these are quite consistent across the different zones. And that again indicates that this is quite a healthy cornea, even though this individual has undergone refractive surgery in the past. So here, I would not hesitate to use even a multifocal IOL. There is, in this particular case, no need for a toric IOL because as you can see, there is not much of astigmatism. When you look at this cornea, on the other hand, you see that there is astigmatism, there is cylinder. You see that this histogram is widely spread out, which you do expect in a case of astigmatism, but you see that the standard deviation here is quite low. Now, this is indicating that this is a regular cornea which has astigmatism, and therefore you can consider a toric IOL here. And if the individual wants a multifocal, you can still go for that as well, because you can see that this is a healthy cornea with astigmatism. It's not an unhealthy cornea with irregular astigmatism. On the other hand, when you see a case like this, you can see the histogram is very widely spread out. You can see the keratometry values here are all over the place, and the standard deviation is extremely high. So an individual like this, you should not be choosing a toric IOL, and absolutely no multifocal IOL in this case. So this is how I would go about choosing which individual I can go for a toric IOL. And now, when you're feeding these values, you can feed it directly into the ASCRS online calculator. If you're planning a toric, like in the case that I showed you, these values of the keratometry values can be fed directly into the Barrett True K toric calculator, which is meant for these eyes. So moving on to individuals that have corneal ectasia. So again, IOL power calculations, not just the toricity, but even the IOL power calculations by themselves in keratoconus are challenging. And the reasons are that this is essentially irregular astigmatism. You do have difficulties in estimating the effective lens position as well here. And usually you end up with a hyperopic refractive error post-operatively. The cone location in case of keratoconus can also influence outcomes. So when you're choosing your IOL power, particularly toric IOLs in keratoconus, what is important is that you should be aware that this is just an astigmatism debulking procedure. You are not trying to eliminate the astigmatism. And a lot of keratoconus patients are happy with RGPs or scleral lenses. So those are patients that you should not be considering toric IOLs in. Always under-promise in these patients and counsel about the possibility of a refractive surprise and tell them that you're just trying to reduce the astigmatism here, not eliminate it. Now, which is the right formula for choosing the IOL power in keratoconus? So, literature has shown that it is essentially the best formulas for IOL power calculation with the most accurate outcomes are the Barrett True K formula, the Kane formula for keratoconus, and the SRK-T formula. Now, my preferred formulas again are Barrett True K toric calculator when you're choosing a toric IOL. Here you have the option of selecting that the individual has keratoconus, and the Kane formula for keratoconus also works very well when you're considering a toric IOL. So the considerations of choosing whether to use a toric IOL or not in keratoconus, my decision making is quite similar to what this literature, this review article in Current Opinion points out. So the most important thing, of course, is that the keratoconus has to be stable. If it's not stable, definitely no toric IOL. Then you look at how severe the keratoconus is. If it's mild to moderate keratoconus, which means that the keratometry is less than 55 diopters, you can consider a toric IOL because that has reasonable outcomes. Whereas if it's very severe keratoconus, the keratometry values are more than 55 diopters, then absolutely do not place a toric IOL. And when you're, in terms of your IOL power selection, if it's keratometry values less than 48 diopters, you can go for plano. But again, as the keratoconus is more severe, you should be targeting more myopia in these patients because you expect a hyperopic surprise to a certain extent. There is another additional consideration is centered cones in keratoconus usually tend to do better. So if you have an extremely decentered cone such as this one, it would be a good idea to regularize the cornea either by placing an intracorneal ring or by doing a topo-guided PRK prior to your cataract surgery, and then after a few months doing your refractive, your IOL power calculation, and then going in for a toric IOL. So moving on to eyes that have undergone keratoplasty. So the prerequisites here are suture removal should have been done. The refraction should have been stable. The visual acuity prior to the development of cataract should have been at least reasonable. Otherwise, there is no point of considering a toric IOL in these cases. Also, the astigmatism should be regular to the extent possible. The outcomes of cataract surgery with toric IOLs in keratoplasty are reasonably good. Of course, they are going to be lower than virgin eyes, and that's been documented as well. What about when you have asymmetric or irregular astigmatism? Here, in a lot of post-keratoplasty eyes, you do have some component of irregular astigmatism. Now, similar to keratoconus here, you can use them to reduce spectacle dependence. You can use them to debulk the astigmatism, but you cannot use them to eliminate astigmatism, and that's something that you should be aware of. There are a lot of post-keratoplasty cases with huge amounts of astigmatism, and not many toric IOLs are manufactured in that range, such as this patient who was post-DALC, and you can see has about more than 12 diopters of corneal astigmatism in these cases. You can also see that there is some amount of asymmetry. The the standard deviation is quite high. You can see that the inferior ring of the bow tie has more cylinder has higher keratometry values than the superior ring. So there is asymmetry. There is some irregular astigmatism component here as well. But I did choose to go ahead with the toric IOL after counseling the patient because I do believe that I can reduce the extent of astigmatism. If this patient was using scleral lenses or RGPs and was happy with them, I would not have considered toric IOL. But this patient was not happy. So I decided to go for a custom toric IOLs. So there are custom toric IOLs available now which can be customized to up to 20 diopters of astigmatism. These are slightly bulky IOLs, need a slightly bigger incision, but they do very well. And this patient is doing extremely well with just 2 diopters of cylinder on refraction and having a visual acuity of 6.9. So you can consider this in patients that have high amounts of astigmatism. And literature also reports that these give you extremely good visual outcomes. So to summarize, good case selection and good preoperative planning is essential in achieving good outcomes in irregular corneas. The outcomes are going to be inferior to healthy corneas or virgin eyes, and that's something you and your patient should be aware of. Toric IOLs are essentially astigmatism debulking procedures where you're trying to reduce the astigmatism in cases with keratoconus and in cases with penetrating or anterior lamellar keratoplasty. And therefore, it's very important to counsel your patients well and set the right kind of expectations. Thank you.
Thank you, Dr. Tushar. I think
Thank you.
that was quite enlightening that yes, we can have toric IOLs in these special situations and how to deal with them. Thank you so much. That was a wonderful
Thank you.
presentation. Any
Thank
questions from the audience? For anyone of us? Sir, any comments from you, sir?
No, I think Tushar has covered it very well, and essentially the crux is that the counseling is very important part especially in cases like this, keratoconus and post-PK patient. I've also done many cases, so we need to counsel that we are trying to reduce down that if you have 10 cylinder, maybe you may left with 1 or 2,
Yes.
so you should not be
Yes.
fighting after the surgery that is not been eliminated completely.
But
So-
definitely that will improve the quality of life and quality of vision.
Yes.
that-
So, but counseling is very
Yeah,
important part.
true.
Yeah. Very nicely covered, Tushar.
So I think with that we come to the end. Can we have a group photo?
Yeah.
Also, I would like to